Well, you know that ATHS is a wonderful congress. Well, you know, those of you who've been here before. There are plenary sessions in the morning, so this is like the main course. And these are world-level sessions, international sessions, and there are different languages. And this gives us the possibility to access renowned researchers. And then there are workshops and parallel sessions, and this is a little bit like an appetizer. And well, you can just pick what you want and choose among different topics. And then there's the industrial symposium, and some people think that it may not be important, but actually ATHS does make an effort so that industrial symposia is interesting. So,
Donc, je vous présente Fadi MEROUEH qui complétera, mais qui est...
So let me introduce Fadi MEROUEH, who's going to complete, but he's an addictologist. And, well, he's got a great experience. He's going to give us an overview on, well, the state of the art of care regarding opioids in France, but also with somehow a European perspective. Thank you very much. Thank you very much for allowing this symposium, and it's always good to be next to Marc and Maurice. I'm going to give you the state of the art of care in France, but I'm also going to tell you about the most important points so that we can discuss afterwards. So this is my conflict of interest. We have to see that half the opioid users in Europe receive an agonist treatment for opioids. So this is half of the population, and these estimations may vary between 10 to 80%. And we know that agonist treatment is the main approach for treatment to opioid dependence in Europe. And there's, of course, a great deal of therapeutic options that are available. And, well, we know that they allow us to reduce the number of deaths related to opioids. It's thanks to the introduction of this treatment, and also it leads to high-risk consumption has decreased as well, and we know that there's less people injecting IV drugs. But today, what's really a matter of concern is the synthetic opioid use. And it all started in the US, but also I have to say that in Europe, it's really coming up very quickly. And there's also the non-medical use of medication opioids that is a great problem nowadays. So we have this high-risk opioid use in Europe. We see that France is in between. Actually, it's not one of the worst, but not one of the best countries. And now, if we think about the efforts for agonist opioid treatment, well, in France, we started later than other countries. But in prisons, we did very well because it all started very quickly. It all started in 1995 in France. And here we see the number of people. So we see an evolution between 2007 and 2007 for people receiving this agonist opioid treatment. But since 2007 and then up to 2017, and then later on, there has been a kind of plateau when it comes to this treatment. And we see that in France, there's 40% methadone and other treatments as well. It really varies from one country to the other. And here, well, France is one of the 9 European countries where we are treating more than half the population. So, and we are also the ones give more treatments to opioid users. And now, who is the beneficiary of this treatment? Well, we see that the number of women is starting to increase. There's almost this parity. And regarding the age, we see that the age is like phased out. People who were treated in 2011 are treated today still. And the age is now 30 to 45 years. Here we find the highest number of people who are treated. So we can say that France is doing well because we're at 50% of the population who's treated. But actually, what happens is that there are many challenges to face. And we see that there's regular activity of GPs that is decreasing. In the last 10 years, it has decreased. And then the estimations for 2025, there's going to be less GPs treating this as well. And of course, if we think about the different regions, we also find a high heterogeneity. We have here the comparison between the number of GPs in each department, and we see that there's this difference. And when it comes to addictology, we see that only 5% of GPs prescribe 80% of the treatments. There's a second problem. Besides the decrease of GPs, it's the dosing. In France, we misdose. Actually, there's 8 milligrams of BHD, 50 milligrams of methadone. And for craving, we were talking about craving, I think that low dose, it can be a source of craving. And if we think of retention to treatment or tolerance to treatment, in the first year, there's a high drop of patients who started on methadone or other treatments, and then they drop. So maybe it's a problem with the dosing, or maybe we have to review the situation. And also another problem is the opioid painkiller use and psychotropic use in patients receiving other treatments. And here as well, we see that there's smoking is increasing, cocaine use is increasing, cannabis as well. So are we really treating the right pathology? Are we really treating the person? We have to wonder about this. And again, we're finding very low doses of treatment, and this can trigger the consumption of other substances. Another problem is misuse. There are different studies that have been carried out in France, and we see that misuse is pursued in France, and we see as well that even though there's a slight reduction of BHD misuse, there's an increase of methadone misuse. So, and I think that actually methadone is easier to misuse and to traffic with. And the last point that we wanted to make is on the study made by Graham, the Graham study, that shows that today we have this trend, this increasing trend to use other drugs than heroin. And we see the number of deaths related to this. So maybe we should start thinking about this problem. So as a conclusion, well, I think that we need to preserve, protect, and increase the access to opioid agonist treatment. We need to raise awareness and fight against stigma. We need to train healthcare professionals. This is a very important problematic. We need to work on reducing misuses. Regarding naloxone, for example, we're a little bit lagging out in France, and we need to increase access to primary care. So yes, let's not forget about primary care for these people, and we need to fight against excessive prescription. Thank you very much.
Merci Fadi. Ce que je voulais dire tout à l'heure, c'est que on fait les deux présentations et après
Thank you, Fadi. We'll have the two presentations, then we'll have a discussion. Now I'm going to hand over to Maurice DEMATTEIS, who is professor of addictology in Grenoble, and is going to talk about these complex issues. Is going to start from a clinical case to show a strategy to clarify when it's complex. Maurice, thank you. Since it's complex and you want to simplify, don't speak too fast so that we can all follow and still be on time so that later we have time to have an exchange to discuss the clinical case, the interpretation of the epidemiological data we have. Thank you, Marc. Thank you for this invitation to participate and to present this subject, which is it's a dimensional approach in the treatment of opioid use disorder in complex situations where professionals have difficulties. It's a situation which may first seem complex, and it may be simplified by a dimensional approach of the clinical evaluation and the treatment. Let's see how my interest, and now let's go to the clinical case. This is a 32-year-old patient. We received her in 2017. She consumed benzodiazepine, codeine, and she consumed massively by full entire boxes. She did false prescriptions. She was there was cocaine, alcohol, and she smoked, and she also had other behaviors, food bulimia and self-mutilation and other compulsive behaviors. And this patient combined all these consumptions and uses. She had very strong craving for drugs, for medicine, anxiety, panic attacks. She spent a lot of time in bed. She didn't get out of her house. And in terms of dimensions, there was a major emotional instability, risk-taking, and a suicide desire. So this is a chaotic picture. And then we look at the patient. She's alone, but she doesn't have any support. When you look at her history, it started a long time ago, and it's going to give answers to the questions we had a few minutes ago. This patient, when she was 5 years old, parents divorced. There was a sexual abuse, which contributed to the sexual behavior of the patient, food problems, and then different combinations of consumption, alcohol, cocaine, sex, self-mutilation. And then she did a lot of sport at very high level. She was very highly performant in her studies too, and with a need to accompany her difficulties with very different consumptions. She had consequences. She had hepatitis due to codeine and paracetamol, and psychiatric hospital stays. Psychiatrists focused on the behavioral disorders, bipolarity with different prescription, lithium and other thyroregulators with consequences in on a thyroid and the diagnosis of a borderline personality disorder. So this is years of treatment where the patient was in a going nowhere. And in this type of situation, which is complex and chaotic, we can analyze the situation very simply. This is a neurologist, pharmacologist who's talking to you. If we look at the substance use disorder, we have to understand why she's consuming. We just have to ask her why. Not only why, different, we can look at motivation. What is the role of the product in the functioning of the individual? Sometimes it's hard to express because for them, craving is a major element because you never consume by accident. In the description of the patient, she explained the motivation, the underlying consumption motivation. The craving is not constant. It can fluctuate along the day, throughout the day. It's we can evaluate that at different times of the day. We can see this is a quantity uncontrollable. So the patients may not control the consumption. And very often we're going to find avoidance strategy. What the beyond the product, there are the other consumptions or the other uses that are associated. We can evaluate the first consumptions. We can use another questionnaires to measure the intensity of the addictive behaviors to see how the patient, because she doesn't have her preferred product substance, she goes to other substances, tobacco, internet, and just on a functional analysis of the consumption, tell me how you consume and when we can explain the situation. Several situations where on a binge basis, binge drinking, binge eating, watching, drugging, sexing is underlain by impulsivity. We have two other dimensions. So the patient is someone pragmatic who is going to try to manage her problems based on what is available. The individual is in the center of the environment, and there are different strategies to manage that. Let's listen to that patient, what is underlying her needs. It's in English, and you have it in French too. Are you tramadol, lamaline, or Seresta? How did you choose between the different products? It depends on the intensity of the anxiety. If it's too overwhelming, I took tramadol, lamaline to get rid of the anxiety. And alcohol, when it was evening anxiety, I mix alcohol with medication. I try to get rid of the anxiety by mixing everything. Behind your craving, there was an emotion and anxiety. Yes, always. Regardless of the situation, all your consumptions were motivated by anxiety elements. Yeah, anxiety or when I felt really bad, I could no longer cry because I was suffering. I had too much pain. So I tried to get rid of that by taking medication. What about food? Well, when I've anxiety all day, I use food. I binge on food. So you select the product depending on the intensity of the anxiety. Yes. So this shows that the patients, they have their own range of behaviors. They use different consumptions that they associate depending on the need to manage the situation. So it's a matter of balance. So we have to understand that to help the patient. So this has consequences on the psychic. She spent her time in bed, didn't do anything. When we look at the levels of anxiety and depression, with alteration, a major alteration of her quality of life. Sleep is very important. It's an essential aspect to always consider in our patient. Today, in the opioid use disorder, the patient have sleep disorders, and to manage that, to manage sleep is one aspect of the treatment. Somatic consequences. She had hepatitis medication due to medication. Comorbidities. We talk about dual pathology, and today, so we, between the underlying issue and product consumption, both are going to get worsen, and this gave a very complex clinical situation. The dimensional approach is essential. Impulsivity is another dimension. TDAH is you have to associate the autistic spectrum disorder, which is a major element in neurodevelopmental disorders, and emotional dysregulation, which is very frequent, including in addictive issues associated to the post-traumatic stress. And beyond the category diagnosis with a dimensional approach, this patient, I do that during the consultation, a high level of anxiety and depression, impulsivity, alexithymia. All this, when we have a personality questionnaire, it's a chimera. Finally, there were neurodevelopmental problems in childhood, autistic spectrum quotient, and traumatism elements of the abuses she suffered when she was a child and which lasted for years and years. In the end, even if you're not a psychiatrist, but you have an opioid usage disorder, you have very efficient medication, buprenorphine. You saw the importance of adapting individually the titration, because anxiety, as the patient said, was the source of craving. The fact that you increase the treatment is going to decrease the intensity of the different dimensions. To understand why it's important when you assess a patient, it's important to systematically look not only to look for other consumptions which belong to the balance of the patient, which is used depending on the needs of emotional management. We can add other medication. Even if you have an ideal titration, it's not enough, and this can be proposed when we can. When we consider the other medications, the ones proposed to the patient, you can again show the different dimensions of the individual, the neurotransmitters. For instance, the opioinergic system is implied, craving in general, anxiety elements, depression, compulsion, impulsivity. Therefore, it's important to customize the treatment. If it's not enough, we're going to add other medication. Here we use ariprazole, which was very effective, up to 30 milligrams per day. She was not psychotic, but she had a major emotional dysregulation, and she responded very well to the treatment. again, we can propose that depending on the disorders that are identified, but it's not enough, you understand. Beyond the medications, there is some work to deconditioning in all the addictive issues and behavioral issues. There is an anxiety and major behaviors, and we have to help the patient. There is emotion, consumptions, and underlying vulnerabilities, the context. So withdrawal is not enough. You have to work on every aspect on the elements that encourage craving. If we start from the basis, the sleep, the living conditions, when we increase the treatment, the needs disappeared. So you see how much it's a global vision of the individual that we must have. And then we work on psychotrauma with different approaches, and we can go further. This is to have a better quality of life of the patient. In the end, even if you're not a psychiatrist, if you're not specialized in assessment of the patient, you have to look at the different aspect of the patient and use the opioinergic treatment to reduce this chaotic situation and to propose individually the different approaches from both pharmacologic and not, taking into account the living conditions, to have to improve the functioning of the patient. We have very effective medications. We have to know how to use them and customize them. I thank you and my team too.
Pour cette présentation rondement menée, donc de ce cas complexe que tu as bien.
Thank you for this presentation. Before we take the questions, do you want to have a comment? This complex case shows that we shouldn't focus on one product. They see us because they consume heroin or cocaine, and if we focus on that and we forget about the rest. So here you showed this case, your patient shows the reality of all our patients, maybe with different traumas in childhood, but there's always an anxiety, which is at the source. And you look for relief from anxiety. If the patient cannot express their pain, they have to find some relief. Yes, this is a very functional approach, and the objective is to slow things down, because when they have chaotic consumptions, this contributes to the dysregulations, and it's even more complex to understand the situation. It leads to alexithymia. When we did the interview, she was stabilized. She was able to describe things, and we see how much we have another clinical picture when we adapt the treatment. So we have to go beyond the representation, preconceived ideas, and to identify the different dimensions of the patient. And here you focus on the patient, not on the substance, and it gives you elements of customized therapeutic strategies, because the patient is going to get better. At the beginning, she was against the psychotherapeutic approaches. What was interesting is when she was more peaceful, she had no massive dysregulation. She could go into different types of treatment, and she describes all the approaches she received and that she used today. She went back to school. She got married, has a child. So and she was first in her promotion in her studies. So we have to help patients to project themselves beyond a situation which may seem lost. And the second problem is benzodiazepines, which are too much prescribed for these patients, and it hides the real diagnosis of these patients. When you stop the benzodiazepines, it's easier to look for them, to look for the causes, look for the best treatment with them. I think that the problem of our patients is that they are all taking benzodiazepines. Why? Because they're part of the why they use the medications when there is anxiety or insomnia. Automatically, not only our patients work on automatically, the general population, France, is one of the major consumers of drugs, medications, and benzodiazepines. It's very easily prescribed. The concern today is that opioids are more available in France, and this is transferred on the opioids with harmful consequences. The opioids are more harmful, and today we have patients who are going to use opioids for self-medication. They did it with tramadol, and in the DTA investigation in the general population, the first cause of death is tramadol, then morphine, codeine, and this patient consumed tramadol, codeine. So she was a high risk. She had a high risk of overdose death. Thank you for these first comments. Now we're going to take the questions. Let's see. Good morning, Nathalie Berge. I'm a doctor ecologist in Alsace. Concerning a substitution, this patient was only taking tramadol in the opioids, tramadol, codeine, and you seem to say in your presentation that TAO had a positive impact on emotional regulation, on stability. Does it mean that in terms of complexity of the poly-addiction, we could hope from a neurobiological standpoint that the TAO could have an action on the evolution of the behaviors and the management of these behaviors. In fact, one of the properties of this treatment is a long-term of action. Here, you work like a yo-yo, and one of the therapeutic elements is a long-term of action. Buprenorphine, methadone is in the long term. You get rid of fluctuation that leads to dysregulation of the patient. Secondly, today we know that there are different dimensions and different receptors involved. They are real psychotropes. These medications can work beyond acting on the opioid use disorder. They work on associated vulnerabilities, and there is a literature on that. In patients without opioid use disorder, we use that when they don't work. They have no success with other treatments. So today, we have elements in favor of these medications in these clinical situations that are complex. And potentially, opioids can be a therapeutic choice. Good morning. Thank you for this ATHS Biarritz, which started very strongly and it's extremely interesting. I have two short questions. Differences in terms of use between agonists such as methadone and partial agonists as buprenorphine, and when we use MP buprenorphine when we prescribe naloxone in prophylaxis, intranasal and intramuscular, are there any specificities concerning their efficiency? The difference between the nasal first question was recommendations about the agonists such as methadone compared to partial agonists as buprenorphine, depending on the associated comorbidities. And for naloxone, nasal or muscular form. In case of long-action buprenorphine, are there any studies which show the efficiency? Should we use nasal or muscular injection? Let me take the first question. In fact, what's interesting is that they have different therapeutical effects. Methadone is more sedative and anxiolytic. But in fact, we can always start with buprenorphine. That's very interesting because we have situations that can be very chaotic. And we say the patient could justify methadone because we realize that some patients start with buprenorphine. It's efficient because we help them in reducing dysregulations associated with consumptions. The advantage is that everybody, any doctor can prescribe buprenorphine, so that's practical. And if it's not efficient, we can always then go to switch to methadone. So buprenorphine can be administered faster when we have massive consumptions where with binge consumption, it's less dangerous to start with buprenorphine than methadone. We show that in a drum study. Unfortunately, methadone is involved in death. So two therapeutic profiles, especially in terms of getting rid of the anxiety. Things were described. It's interesting to use methadone. It's interesting in pain because it's very efficient when you have neuropathic or nociplastic pains. Methadone is the choice treatment, but if not buprenorphine, you can always start with buprenorphine. When there are consumptions that persist, then you have to choose between the two, looking at the cardiovascular effect or medication compatibility. So it's quite simple. You can start with one and switch to the other, unless there are specific situations where you will propose one or the other. This is important because sometimes in the French context, we feel that methadone is more efficient for more complex cases, but when we look at the data, we cannot really, there's no difference in efficiency, even though some data show that they're differential responders. Some individuals respond better to one or the other, but we don't know that beforehand. And do not forget the associated care. Someone who starts a methadone treatment has more, not always, but has more associated care. So that can give the impression that it's more effective. The second question is whether long-action buprenorphine. Someone is receiving a buprenorphine, long-action buprenorphine treatment. can you manage the risk of overdose? I think with the long action, yes, there is a very clear action on overdose. This is proven, but at a strong dosage. And we have proof. This afternoon, there will be Dunlop will talk about people getting out of jail. If they receive that treatment, there are less overdoses or no overdoses compared to a few years ago. So buprenorphine, long-action buprenorphine, has a protective effect on the overdose as such. For the other products to be efficient, you need to have a high doses. It's a matter of competition. So buprenorphine will be fixed on the mu receptor and it protects from the overdoses. But you know that even when you have buprenorphine, but then you need there's an affinity with a mu receptor. It's better to have a little more than less because it has an effect with co-consumptions because it's protection from the risk of overdose. And there's effectivity between intramuscular or nasal. It's
René Marek, Paris, but also I have a practice in the Caribbean. Thank you for this presentation. Thank you also, Marc and Fadi. I would like to pick up on the example of a patient of 32 years of age, and you explained very well that we need to adapt to each individual because they all have different personal reasons for which they use drugs. And it's true that the motivational interview that you mentioned, of course, the motivational interview is key in our practice because the patient has to stand at the center. And you said that a female patient had a hard time explaining initially. And it's true that it's important that healthcare professionals are trained in conducting that motivational interview, also to assess craving, but also to better manage our patients. So that was more of a statement than a question. And again, I wanted to thank you. Are there other questions? Also, do not forget what Fadi talked about epidemiology. I have a question, a short question. In the French context, the average doses of buprenorphine is about 8. 65% of patients using buprenorphine are using between 8 and 24 milligrams. And for methadone, 50 milligrams. So what is the right interpretation? Well, maybe there's a factor of fear. In France, for a long time, there was this fear that 8 milligram was a lot. And above 8 milligram, there's no market authorization, or there was no market authorization, or the maximum doses was 16 milligram. Now, with the prolonged action, we can go as high as 32 milligrams. But I think there's always that fear that there's a misuse of that drug. And on methadone, a number of practitioners were afraid to give too much. So I suppose that there's a lack of training and associated fear. And same goes, buprenorphine intrinsically has a protective factor because it has a strong affinity to the receptor. But methadone, provided it has a right dosage, is also going to be protective. However, we need to have a right titration, a progressive titration, Of course, when you have a patient co-using different drugs, you shouldn't give them only 40 milligrams. They run more risk of overdose with 40 milligrams than with 80 milligrams or more. Of course, we reduce their mortality rate. Yes, there's a fear from the patient himself or herself, but also the healthcare professional. A high dose for a patient means, well, I'm very sick, I'm going to be on treatment for a long time. And so the patient, when they come to your consultation, they spend a couple of minutes with you, but they're going to spend most of their day outside, and they're going to have fellow users or other people telling them, oh, you're taking too high of a dose. And so what we see in our consultation are a number of patients where they do not develop alternative compensation or coping mechanism because they did not receive the right dose in the first place. So they receive too little, and they compensate this little dosage by extra consumption. So we need patients to understand, but also our colleagues to understand, because we work with or without collaboration with other healthcare professionals. And so we need to raise awareness of the entire profession. And of course, the objective is not necessarily to decrease the dose. The project is quality of life. The project is to have long-term strategies. Of course, we'd like patients to develop coping strategies and coping mechanisms, but if we reduce the dosage too early, we're going to create an imbalance, and they are going to compensate by using more products again. So there's a lot of education that needs to be done. So during the motivational interview, but it has to do with psychoeducation, therapeutic education of our patients, but also of our colleagues. We need to explain to our colleagues why we start a treatment in the first place. Titration is important, and also explain to them that it's important to keep that high dose for a rather long period of time. And then, of course, we're going to decrease the dose. But so we need that collaboration. And so we need to work with the patients, the healthcare professionals, and to pick up on that lady, 32 years of age, there was a very nice ending to her story. Of course, entourage was putting her under a lot of pressure because they did not understand why she would take such high doses. And often we realize that the patients are not the one asking for a reduction in a dosage, but rather their friends or colleagues or family. And so the fact that we have new administration modes, new galenic modes, changes the ball game, whether we have long release or whether we have a different form of products, it helps remove the stigma. On psychoeducation, all patients, when they are taking a substitution therapy, they are going to they are not going to get the pleasure that they had with drugs. And so sometimes there's going to be a co-consumption. So if we increase methadone, they are going to crave less alcohol. So some of them reduced the quantity of methadone that they were prescribed in order to be able to drink alcohol. So there's also this psychological dimension. We need to talk with our patients. You need to understand the why, and you need to investigate the potential psychiatric comorbidities so as to get the right situation and the right dosage in the first place. We are reaching or nearing to a close. Well, I suppose that those who left are already eating, and maybe there will be nothing left. So I know that you're slightly concerned about that. And maybe a last question from the public. I'm a teacher, but also a researcher in the Ivory Coast. And I'm here also because I have a poster displayed. From the different conferences, I hear that the environment plays a central role, the patient's environment. And apparently, of course, we raise awareness of parents, but maybe not enough, because of course, parents' emotions may ripple on the patient's behavior. And so I think that we should take better consideration of the environment. So I'm talking about parents, but also the general entourage. So as to see what are the external influences on a patient. So that was my first statement. The second thing I wanted to say is that generally substitution treatments become the main substance of abuse. So substitution treatment becomes substance of abuse, and in the Ivory Coast, we have a number of teenagers who are using methadone, for example, as a strong dose. I'm talking 250 grams, and so they use 250 grams mixed with other drugs, and so polyuse of drugs. So my question, what can we do against that type of use? What can the specialist or the medical doctor do to prevent overdose? And what are the substances that can help our patients? What are the medications as well that can help those patients with that type of polyuse? So please, a short answer, because we're very close to the end. When you think about a product, whether it's a drug or an illicit drug, you know, heroin initially was a treatment aimed at replacing morphine. Now, when methadone is not used with the right objective, it can because, of course, a drug of abuse. And it does contribute to stigma of those medications. Therefore, the interest is to understand why they abuse those substances. And of course, you need to tailor your treatment. You need to understand the why, once again, why they abuse drugs, and you should take everything into account. And one of the different factors is the environment. And you're right in saying that you may have the best treatment in the world. If the patient lives in horrible conditions, it's going to be very hard to help them. And talking about that, of course, the entourage can be highly protective, but sometimes deleterious. And sometimes deleterious because they do not understand the disease in the first place. That's also the reason why we have an awareness-raising program, and also a program in order to involve the family, in order to work as a team. So we need to create a system, we need to have a systemic approach, and so we have functional integrative approaches in which we take into consideration the family, but also the wider entourage. I would like to answer your questions as well. Africa, from what I understand, in Western Africa, because I worked in Senegal, Ivory Coast, Mali, and other countries of the western part of Africa, up to now have not been touched by the crisis of cannabidiol and the misuse of heroin and things, but things are changing, have changed in the last 2 years. Yes, and I would like to finish. We have a number of patients with an improper use of the treatment because they have an under-treatment. Depending on whether the drug is administered sublingually, intramuscularly, or per os, you are going to have a different biodisponibility. So you need to ask the right questions, and you need to have the right dosage that needs to be tailored to the patient's needs. Yeah, it's true that when methadone or buprenorphine are misused, was demonstrated by the case of Dr. DeMatteis, you shouldn't only scratch the surface and think that there's some misuse for bad reasons. You need to look into the underlying psychopathology of said patient to see why they misuse the drug in the first place, and see what are the underlying conditions that the patient is trying to manage. Unfortunately, time is of the essence, and we need to come to a close. Thank you very much for being here, and we shall resume at 2:30 sharp.